Hello, you are watching the Saturday, August 1st edition of Rational Nuggets. Are you ready to be infused with some rational thinking today? I have been reading and studying a number of articles, and all but one of those articles are in a preprint or pre-peer reviewed state. Makes sense because what we have to do at this point is take the best information we have available to us on any given day and make rational decisions based on that information. I have also watched an hour-long interview of Robert Redfield, who is the director of the Center of Disease Control and Prevention. As usual, I will be including links to all of the sources that I reference in the description of this video below. The too long didn't watch summary of this video is this. Based on the data, asymptomatic spread of SARS coronavirus 2, which is the virus that causes COVID-19, the infection, is almost certain, meaning that an individual that doesn't show symptoms can possibly spread that illness to somebody else. However, this is only in high risk environments or environments where we are expecting close contact with others. The CDC defines close contact as less than 6 feet of physical distancing for a period of 15 minutes or more. So, in high risk environments with close contact, face masks provide varying but effective levels of protection against the spread of this virus as well as other pathogens. However, what the data informs us of is that it is irrational to mandate universal masking as the risk of spreading COVID-19 in incidental contact is quite literally almost zero. If you're interested in a deeper analysis, stay tuned. For the rest of you, though, please spread the good news. There is no reason to live in fear. This knowledge, coupled with the everyday reducing mortality rate of COVID-19, should result in less anxiety, more calm, and more peace among the general population who don't thrive off of fear mongering and panic porn headlines that drive mainstream media. I will now summarize the relevant parts of a few of the articles I have read, which have led me to the conclusions I have come to. The first article I'm going to cover is titled Respiratory Virus Shedding in Exhaled Breath and Efficacy of Face Masks. This article, published on April 3rd, included 246 participants who were infected by either seasonal coronavirus, it doesn't specify which variant of coronavirus, influenza, or rhinovirus. All of these are respiratory viruses. They split the randomized participants into two equal groups. One group was masked while the other group was unmasked. They asked each participant to breathe for 30 minutes while they collected samples to measure viral shedding. The unmasked group contained 10 coronavirus volunteers, while the masked group contained 11. They detected coronavirus in 40% of the samples collected without face masks, 4 out of 10. They didn't detect any coronavirus in samples collected from participants wearing face masks. They studied and found that for those who did shed virus in respiratory droplets and aerosols, viral load in both tended to be low. Low viral load, check. Less than half of the subjects had any detectable coronavirus while being measured for 30 minutes. 30 minutes, no viral load, check. Another finding of this article is as follows. Given the high collection efficiency of the collection method, and given that each exhaled breath collection was conducted for 30 minutes, this might imply that prolonged close contact would be required for transmission to occur. Check. Prolonged close contact. Got it. There was no coughing forced, but coughing was permitted and did happen during these trials. Of the unmasked coronavirus participants, 4 didn't cough. And of those 4, they didn't detect any virus in respiratory droplets or aerosols. So think about that. 4 of them didn't cough, and there was no aerosol spread. And of the remaining 6, they did cough, and 4 of them did have aerosol or respiratory droplets detecting coronavirus. The article states a limitation of the study was that they did not confirm the infectivity of coronavirus detected in exhaled breath. Okay, we'll assume that the particles were infectious for the sake of argument, but keep in mind that this is going to be a common theme in all the studies that I cover, is that they haven't confirmed the infection possibility of the viral particles they find. I would also add the study was limited due to its small number of participants. This next study is significant because it was not a control test, but rather a collection and analysis of the occurrence of airborne SARS-CoV-2 at 30 sites in 2 designated hospitals and public areas in Wuhan, China. The study is titled Aerodynamic Analysis of SARS-CoV-2 in 2 Wuhan hospitals and was published on April 27th of this year. The 2 hospitals in this study have very different characteristics. One was a traditional hospital, while the second hospital was a field hospital, which was converted from an indoor sports facility or exhibition center. Findings from this study include, in general, very low or undetectable concentrations of airborne SARS-CoV-2 were found in most of the patient areas of Renmin Hospital, suggesting that the negatively pressurized isolation and high air exchange rate inside the intensive care units, coronary care units, and ward room of Renmin Hospital are very effective in limiting the airborne transmission of SARS-CoV-2. Remember, these are environments where sick patients are living around the clock, and yet low or undetectable concentrations were found in most of the patient areas. Continuing with findings from this Wuhan study, the highest concentration in patient areas was observed inside, wait for it, a patient mobile toilet room at the Fangang Hospital, and that's the field hospital, the makeshift hospital. This toilet room was a temporary room of approximately 9 square feet in area without ventilation. Airborne SARS-CoV-2 may come, they hypothesized, from either the patient's breath or the aerosolization of the virus-laden aerosol from the feces or urine of a patient during use. In review, virus concentrations are high in non-ventilated small areas. Check, we get it. There are some additional significant findings from this study as well. In public areas outside the hospitals, they found that most of the sites had undetectable or very low concentrations of SARS-CoV-2 aerosols, except for one crowd gathering site about 1 meter from the entrance of a department store that customers frequently pass through and the site next to Renmin Hospital. They write that although both sites were outside buildings, it is possible that individuals infected with SARS-CoV-2 in the crowd may have been the source of virus-laden aerosols during the sampling period. The results suggest that, overall, the risks of infection are low in well-ventilated or open public venues, but they do reinforce the importance of avoiding crowded gatherings, or if you must go to a crowded gathering, then consider putting on the mask for your own safety if you don't want to get sick. If you want to get sick, then that's your choice. Another interesting finding of this study was the high concentration of the virus found in the healthcare workers' changing area. They hypothesized that the source of this was the resuspension of virus-laden aerosols from the surface of the protective apparel worn by medical staff while they are removing the equipment. So, some changes in protocol were implemented to reduce airborne virus particles in the changing area. Makes sense. In summary, this study's findings suggest that toilet use by patients with COVID-19 and crowd gatherings that include individuals infected by coronavirus are non-negligible sources of airborne SARS-CoV-2, although the infectivity of the virus is not known. Again, they don't know whether or not these viral particles in the air are actually alive and if they can cause infection. We'll assume for the sake of argument that they do. I will briefly mention one other study that I reviewed. This one is titled Exhaled Breath is a Significant Source of SARS-CoV-2 Emission, and it was posted on June 2nd, 2020. This one read a little more like panic porn than the other studies did, meaning it seemed like it was editorialized and had an agenda. The one sentence summary this printed study included states COVID-19 patient exhales millions of SARS-CoV-2 particles per hour. Scary. This study included 35 COVID-19 patients in Beijing, China. A total of 298 samples were collected, including 30 exhaled breath condensate, 26 air, and 242 surface swab samples. So basically, they took 30 close-up samples and got the condensation, and then they had 26 air samples. I'm not even going to touch the 242 surface samples. This article claims the data revealed direct evidence of airborne transmission of SARS-CoV-2 via breathing. Now, there's an interesting claim. However, they don't include an account of an actual transmission from a COVID-19 positive individual to a COVID-19 negative individual. But let's ignore that and just claim what we want. Finally, the last article I'd like to cover, this editorialized research paper has this following sentence. From air samples collected, including those using a robot, one sample from an unventilated quarantine hotel toilet room was positive. I think that there's a little common denominator here. Unventilated bathrooms. Let's stay out of those. Anyway, so they found one sample among those 26 air samples they took in a toilet room where a family of 3 was being quarantined, was staying. So still, lots of articles, lots of research, no evidence that warrants universal masking. The final article I want to cover isn't a research paper or a study, but rather it's a plea. This article, titled Universal Masking to Prevent SARS-CoV-2 Transmission, The Time is Now, was co-authored by none other than the director of the CDC, Robert Redfield, who I mentioned earlier. I'm sure that this man has great intentions. He wants us all to be healthy. I guess it's just easier to scare people into submission than it is to empower them with rational data. In this article, the authors share data about masking in healthcare environments and then take an irrational leap to argue for universal masking. Masking worked in a hospital, closed environments with sick patients and caretakers. Therefore, we should wear masks everywhere we go. That makes a lot of sense. They write, quote, like herd immunity with vaccines, the more individuals wear cloth face coverings in public places where they may be close together, the more the entire community is protected. Note, they don't mention anything about herd immunity the natural way, but they are planting the seed for vaccines every chance they get. It's nefarious. Of course, as one would expect, not really, this group of scientists resort to guilting and manipulating the reader by writing the following. At this critical juncture, when COVID-19 is resurging, broad adoption of cloth face coverings is a civic duty. A small sacrifice reliant on a highly effective, low-tech solution that can help turn the tide favorably in national and global efforts against COVID-19. Or we can be rational about this and wear the masks where they make sense instead. Clearly, this subject cannot be breached without parties involved stooping to emotional, irrational arguments. Here are the facts. Every study in the count I have read, regardless of whether it's symptomatic, asymptomatic, or pre-symptomatic spread, the infection was a result of extended, close contact exposure to an infected individual. There is, of course, much more in these studies and others that we could cover, but that is all we have time for in this Rational Nugget. Please provide feedback below, subscribe, share this so we can help stem the disinformation being spread. Thanks. I'm out.